You.
Do the slides look okay?
Yes.
Perfect.
Okay, so you can go forward, Deborah, one more slide if you don't mind. So we just wanted to welcome everybody today. We are so delighted to meet all of you, to see all of you, and so grateful that you're joining us in this important discussion. Again, I'm Jo Paladino. So today we're really gonna talk about what it's like to go from noticing changes in memory or thinking to getting a diagnosis of it could be cognitive impairment or a diagnosis of dementia. And Dr. Lee is going to start really by talking about diagnostic processes and how to prepare for clinical visits. I'm going to talk a little bit about the challenges of getting a diagnosis. And then wherever there are challenges, there are always opportunities to improve. And so we're going to close really by talking about opportunities to improve diagnosis, communication, and care. And then most importantly, you're going to hear from Carolyn about her experiences. And so I will send it over to Dr. Lee to get us started.
Hey, thank you. Thank you, everyone. I'm so excited that we get to spend this hour together. So as a geriatrician, this is the question I get asked all the time, either directly or between the lines, which is this normal aging? Should we be worried? Or is this dementia or early dementia? And should we be more proactive? And this is a question I get from patients themselves, families, sometimes even colleagues who share patients with me. So the early signs and symptoms of dementia are multiple. It can be things like trouble remembering recent events, being repetitive, misplacing things, confusion with time or place, and sometimes even getting lost in familiar places, trouble with words, trouble focusing, difficulty with daily tasks or with planning that you've done throughout your adult lifetime, changes in mood, personality, or behavior, as well as changes in sleep and social withdrawal. Now, if you're looking at this list and feeling like I meet half of them, you're not alone. These are very non-specific symptoms, and that's what makes it so challenging, right? So if you're having any of these symptoms or you're worried about someone, hold that thought because there are so many other conditions that can also lead to all of these symptoms. Stress alone can lead to all of these symptoms, sleep issues, depression or anxiety. Medication side effects is a huge one as we get more number of medications on board as we get older, most of us, and other medical conditions. So I think what I'm trying to say is have a low clinical threshold to seek care, but don't go to any conclusions just yet. It's important to not to jump to conclusions and to seek care. So whenever I have a consult patient or a primary care patient, there's a memory issue and I do a workup. And let's say at the end of the workup, I am really truly convinced that clinically this is a diagnosis of dementia. But let's say that word hasn't quite come up yet formally for the patient or the family. I always take a moment to pause and think to myself, what's the benefit versus the downsides of bringing up this really upsetting word of dementia, right? And usually, more often than not, I decide that it is important to have this diagnosis more formally out there. And it's usually because of these reasons. Early diagnosis can help us discuss the benefits and risks of certain treatments and specialized services that are out there. It also helps us plan for current and future medical care and otherwise, like settings of care where you might be living. And it also helps us improve with coping and quality of life when we have a concrete diagnosis to work with. So diagnosis to mild cognitive impairment or dementia is usually a longitudinal journey, and it involves many different people and many different puzzle pieces. So I would encourage you to really start by talking with your medical professional. Usually most people start with their primary care doctor, right? So you want to schedule a visit with the health professional. Prior to that visit, it would be helpful to write down some symptoms and changes that you've had in your memory and thinking. This is a highly sensitive and emotionally charged topic, and I think many of us, if we went in without notes prepared, would kind of blank out or become kind of overly fixed on one symptom versus another. So it's nice to write down some objective data beforehand. This is important as well. We really want to know which medications and supplements you're taking because a lot of medications interact with our cognition, and that's super important for us to know about. And I also think bringing a trusted person to the visit can be super helpful, not only because they can provide important information, but they can also be this emotional and cognitive support throughout the process. Again, many of these visits become emotional, where it's a very sensitive topic, and it's so helpful to have that advocate. And this is another tip is I would really dedicate a visit to memory from the onset. So whether that means today, I know there's a lot of things you want to talk about, Doc, a lot of things I want to talk about, lots of competing priorities, but if there's one thing I really want to prioritize today, it's memory. And that's important for us to goal set ahead of time, because usually we have 15, 30 minutes in a visit, and there are many things to talk about. Sometimes that's not realistic, but you can always say, let's schedule a visit, soon, not my next annual, so that we can really dedicate a visit to talk about my memory more in depth. I think that would be super helpful. So during the initial visit, your provider will lead you through a discussion of your symptoms and your history, thinking, changes in memory, also importantly, changes in thinking and behaviors, how your mood's been, how your sleep's been, how your mental health has been. We'll also make sure your vision is up to date, up to date on the necessary checkups, that you're hearing decently, etc. They'll probably also take a social and family history and think about other risk factors for cognitive impairment and dementia. Your provider will also do a physical exam, and that can mean things like checking for your blood pressure and how that differs in different positions, checking for any tremors, and watching how you walk with or without assistive devices. We'll do a thorough medication review as well. After this, we move on to the more in-depth diagnostic testing. So there are different types of tests out there that we can do in the office. These are usually 10 to 15 minutes long. The MOCA exam, the Folstein Mini Mental Status exam, the VA system often uses the SLUMS exam, the RUDIS exam, and then in some rare cases, we decide that 10, 15-minute test is not enough and that we need to go further with a little bit more extensive testing with professionals who are particularly trained to do this specific testing outside that office visit. So this is what a MOCA looks like. It might seem familiar from a prior visit of yours, but basically, again, it takes no more than 15 minutes, and it covers different domains of your thinking. So it covers short-term memory formation, short-term memory retrieval, attention, language, visual spatial skills, and executive function. And there is a cutoff point. So, technically we want you to get 26 out of 30 points or higher. So there is this kind of point cutoff, but it's not only that, we also want to use this test to look at certain patterns that might be emerging, certain strengths and weaknesses in the test and how it compares to the past. So I just want to clarify some terms that are confusing. Cognitive impairment is a diagnosis that's almost black and white. It's a little bit more simple to define cognitive impairment. It means that at a moment in time, you either passed a cognitive test or you didn't. You just made the cutoff or you didn't. So it's a little bit more straightforward. Now, this does not necessarily mean that you have dementia if you tested below a certain threshold. What we will next do is think about a functional assessment. And that's really looking at your ADLs and IADLs. Now, ADLs are activities of daily living. These are things that we do in the bathroom or the kitchen. So bathing, showering, dressing, eating, transferring, hygiene, these things. And then we'll ask about instrumental activities of daily living. Now, these are the things that take a lot of strength outside the bathroom, but in the home, like vacuuming, housekeeping, cleaning, shopping, cooking. And then also there are cognitive IADLs, like managing finances, using a phone, driving, organizing medications. And dementia is a clinical diagnosis a medical provider will make based on a functional assessment. If we really think there is there is abnormal cognition, and that's what's primarily driving a steady fall in functional independence, and we need more and more help with these ADLs and IADLs, that's what we call a clinical diagnosis of dementia. Now, of course, we first will take some time to rule out some other causes. So certain blood tests are very common as your cognitive workup. We want to make sure there are not other mood issues, medications, substances, sleep issues. And sometimes we honestly identify it, but cannot completely optimize it. But we do the best we can before we reach that kind of functional assessment that sometimes leads to that dementia diagnosis. Once we get to that dementia diagnosis, we may order some additional neuropsychiatric evaluation, certain brain scans, and refer you to a specialist like a neurologist or a geriatric practice, some of which have dedicated memory clinics. So some other diagnostic tests that your practitioners might consider, if appropriate, sometimes a brain MRI can be helpful when there's a mismatch between what the person's telling us versus what they're experiencing day to day, but maybe they did perfectly on the MOCA. So when there's a mismatch, sometimes brain MRIs can be really helpful. PET scans are another advanced imaging modality that's increasingly being used, especially in the research world, because it can pick up abnormal proteins that can build up in certain conditions like Alzheimer's. Sometimes a lumbar puncture may be necessary, where we try to look for certain biomarkers related to an Alzheimer's diagnosis. And there are all these newer blood tests coming out as well. And of course, these can be anxiety provoking, sometimes informational, sometimes more helpful, sometimes more harmful. So I think it really depends on the individual case, and your clinician can walk you through the benefits versus risks of doing some of these tests. The word dementia is this umbrella term, right? So as we mentioned before, it means that there is functional changes happening driven by cognitive impairment. And there are very different types of dementia. So most commonly we think of Alzheimer's disease, and that is the majority of currently diagnosed cases. But there are other dementia subtypes like vascular dementia, usually from a stroke history, dementia with Lewy bodies. And here there's a predominant Parkinsonian syndrome or motor symptoms that accompany the cognitive impairment, and frontotemporal dementia. Lastly, I just want to end with this point that caregivers play such a key role in diagnosis. First of all, they really provide invaluable input as we make the diagnosis of cognitive impairment or dementia. They provide collateral information, additional information about a person's daily function. They also serve as important advocates. They provide practical emotional support throughout this journey that is the diagnosis, that is getting to a diagnosis of dementia and what we do afterwards. So with that, I'll pass it on to Dr. Paladino.
Thank you so much. So I'm going to share. Okay, so thank you so much, Dr. Lee. So now I'm going to talk, we talked a little bit about the process of getting to a diagnosis. I'm going to talk about challenges and also some opportunities for improvement, including some research we're currently doing to work on this. So as Dr. Lee mentioned, diagnosing dementia often involves multiple tests, multiple visits with different clinicians, which may have been some of your experiences, because there's ruling out other conditions. There's potentially tracking how people do on memory evaluations, memory assessments over time. And so what that really can mean for patients and caregivers is that it can sometimes be a prolonged time between having these symptoms and getting to a diagnosis. And that means sometimes living with kind of feelings of uncertainty as we're getting to that point. And so that's one way that this diagnostic process can feel challenging or complex. Also, some people have long wait times actually for seeing specialists, which is another challenge that comes up. In addition to that, as we said, memory assessments are not perfect. They're really a moment in time, and they depend on how they're delivered by the clinician. They depend on how someone feels during that visit, a person's education or cultural background. And something that we call performance or test anxiety is quite normal during these evaluations, and that can make them hard to interpret. Something that we haven't talked about yet is the fact that patient and caregiver experience with actually receiving diagnostic information from clinicians can be very variable. So while some people have talked about having positive experiences, and when I say positive, it's hard to hear the news of a diagnosis like dementia, but those who had positive experiences talked about feeling cared for, feeling informed about what to expect, feeling like they had a comprehensive plan. I think many patients, however, don't necessarily have that experience and describe unmet needs at the time of diagnosis. So, some examples people have talked about kind of clinicians using vague terms or overly technical language that was hard to understand, and that caused confusion. In other cases, people felt like they did not get information about what the diagnosis means or what to expect, and often had to find that themselves, like on websites or online or, at organizations and things like that. And then finally, inattention to the emotional impact of hearing news that could be difficult to hear. And so these are just common experiences that I think we are hoping to work toward improving. In addition, I think it's important to name the stigma associated with talking about memory, talking about thinking, talking about things like dementia. So I think there's a stigma in our culture. There's stigma about aging. There's stigma about, and so this is real. And and one of our goals actually by talking openly with you all about this is to do this process of kind of destigmatizing it. But I also think it's important to name because sometimes people may be experiencing these symptoms, but may avoid seeking care or getting evaluated because they're of fear of being diagnosed, or maybe because they think it's normal aging. So part of this is also education. How do we educate the public about this? There's also variation based on your geographic, your background, your family structure about how we think about aging and how we experience care that may cause delays in seeking care. And actually, in some individuals for whom their primary language, they have a language other than English, some of the terms actually itself for words for things like cognitive impairment or dementia can in and of themselves be stigmatizing. So I think that's important to name. And then, of course, there's fear of losing independence and of discrimination, which can contribute to a reluctance to get tested. So, what I wanted to just say here, feeling kind of nervous about getting evaluated for thinking changes or memory changes is normal. In addition to, I'm a clinician, but I also am a caregiver of my dad who lives with me, who has, he has a diagnosis right now of mild cognitive impairment. And what I wanted to just, and it was actually very challenging for him about getting his initial assessment. So, I wanted to share a few things that we've learned from talking to patients and caregivers and clinicians about how to even talk to people about memory assessments. So here's an example. So the framing language really matters. So this will help us understand strengths and areas that may need support. It's not about passing or failing. So for some people, the term test can actually put you on the defensive and make you more nervous. So this is just an example of another way to frame it. Also, why are we doing a memory assessment? By getting a better understanding of what's happening with your memory or thinking, we can create a plan to address it together. So creating real partnership. Reassuring people that difficulties during this are normal and many factors can affect performance. And then, of course, I think sometimes just acknowledging concerns or anxiety. This can feel tricky, this can feel hard, and giving people the time that they need. So allowing the individual to take time to go at people's own pace. Some patients actually want a caregiver present, others don't want really an audience when they're doing these things. So I think giving people a sense of control over how this happens really matters. The Alzheimer's Association recently put out a great piece in the medical literature about, once a diagnosis is made, you can get all of these assessments and these lab tests and all of these things, but if that isn't communicated in a way that is honest, compassionate, and understandable, and with a clear sense of what happens next, then it can be very hard to plan after that diagnosis. So they put out this piece about things that we should think about whenever we're sharing a diagnosis. So talking about the type, the severity, talking about what to expect in the future, treatment options, safety concerns, and like this holistic picture, psychosocial, resources, planning. So this doesn't have to all happen at once, but the idea is that these are important domains that can either be addressed at the time or in subsequent visits after a diagnosis. And so our team's been doing research. We've interviewed 23 patients and caregivers affected by dementia and 23 clinicians across specialties, so primary care, neurology, geriatrics, geriatric psychiatry, to try to understand what have been your communication and care experiences at or around the diagnosis, and where are opportunities to improve. And we're going to be developing clinician training models based on this work. And so I just wanted to share some of the learnings that we have from people's narratives and voices about communication models that we hope will improve the experience of diagnosis. So, one of the first and foremost things that people talk about is this idea of authentic therapeutic relationships and respectful communication as a foundational piece of communicating a diagnosis. So, here's an example from a patient. I met with a neurologist. I was a little nervous, and she introduced herself, and it was the way she would ask questions and express her concern. I felt connection to her, and I felt very comfortable with her. So, these kinds of things actually really matter. And this is from a caregiver. My mom's energy would change when she would connect with someone she trusted. It gave my mother such an amazing lift to feel seen. And the psychiatrist would say, "Your daughter wants the world for you." He was sticking up for me, which really gave me a moment of light. So, this idea of having respectful communication to both patients and caregivers in those clinical moments is really powerful. The second thing that we learned is creating a safe space to talk about things that could be hard, potentially to talk about. And so here's a social worker. I have a lot of older adults who would pull me to the side and tell me, "I've been noticing my mind hasn't been the same for the past year." And I had to walk them through to say, it's a safe space for you to treat what you're dealing with. So this was a social worker who, the patient in this instance really didn't feel comfortable talking to the doctor quite yet and started with the person that they trusted. And then she helped create that safety to bring her in for additional visits. As you can imagine, everybody has different needs. So some people like to get lots of medical details. Some people like big picture. Some people like to get everything all at once. Some people want their loved one or their family present when they hear this information. Some people may want to do it a little differently. And so this is a geriatrician talking about how what she builds into her practice is actually asking people how they like to hear information, and tailoring it to meet needs. So I ask, what are your thoughts about the causes of your memory changes? How much information would you like to know? And then depending on what the person says, she'll kind of bring up the term, I'm worried that this looks like it is a dementia. And so this can kind of tailor that communication to people's needs. As you can probably tell, emotional response, I think, is really important. So when I come from originally from the oncology world of research, and a patient shared this really helpful analogy, which is, that if you're feeling kind of worried or anxious about something, it can feel like a balloon that you have to kind of deflate before you can move on to other things. And so opportunities to allow people to kind of process hard news can be really powerful. So this is a neurologist who said, when I do diagnostic disclosure discussions, I ask, what are your hopes? What are your worries? And how do we support that? So making sure there's time and space to be present. So the idea of really, validating people's experiences and exploring them can be really powerful. And the last two is this idea of hope and partnership in care planning. And so, when we think about receiving a diagnosis of dementia, some patients and caregivers we spoke to felt that there was, it wasn't clear what happened next, and the follow-up was actually quite long after the diagnosis. And so, how can we change that? And this is an example from a geriatric psychiatrist who talks about how she partners. I want to be as reassuring as possible that they're not alone. How do we manage this together to make sure that you're as independent as possible? So let's make sure you're taking your medications, going for walks, staying engaged, and taking care of the family system. And so this is the idea of a holistic picture. And then finally, people want both, hope in terms of what we do now, and also how do we prepare for changes in the future. We call this in our communication research the hope prepare model, which is a common kind of communication model. And these are the perspectives of patients and caregivers about how important it was to them to get information about what it means to have a diagnosis like this and what to expect. So this is a patient. Well, it was definitely a surprise, but I'm also glad that I have the information because it changed my life in some ways, mostly positive, like paying more attention to lifestyle changes and having a sense of purpose. People have talked actually about this diagnosis causing them to focus on their priorities, to maybe do advocacy. And I think that can be a really powerful experience. And a caregiver saying it was hard for me because I didn't understand what this illness was, but they broke it down for me. They took their time and explained what to look out for, what to expect, what I can do, and where I can go for help. That's actually so important because there could be multiple clinicians involved in somebody's care, and you're thinking, who do I call if something changes or if something comes up? And that caregiver of her mother talked about how powerful that was. So in summary, this is just to say that, emotional reactions are normal and can vary. There could be a sense of relief and validation, also feeling nervous, feeling sad, a sense of grief, and that it's important to give people time to process that. In addition, care planning is really just as important. This idea of kind of creating an action plan after a diagnosis. And when I use the term care planning, I'm talking about creating personalized strategies to meet unique needs of patients and caregivers. These are everything from treatments, interventions, services, resources to optimize outcomes and well-being. And some questions that we ask when we're developing care plans with patients or caregivers. These are questions for you that you can think about. What are your hopes and priorities? What are your biggest concerns or worries to make sure we address them? Who are the important people in your life that you want to be involved in these conversations and in this care planning? I always ask people like what gives you strength or support. People have such powerful prior experiences in their lives that can really that come into these conversations that are so important. What activities are important to you, and what are your current needs, and what are your unanswered questions about now or about the future? We don't ask all these at once, but these are just priming questions that get integrated into care planning processes. And finally, we're in the process of, with input from patients, caregivers, and clinicians, developing kind of a care planning, structure. This is a work in progress, just to be clear about all of the domains that we think are important to think about when someone is living with changes to their memory, to their thinking, or a formal diagnosis of dementia. So there is, of course, optimizing cognitive health. So discussing new treatment options, lifestyle changes to preserve independence, managing other health conditions, access to new research opportunities. Actually, there's so much research going on this area right now. Then we think about broader and overall well-being. So quality of life, coping, behavioral and mood changes, relationships. How can we provide we do a lot of work to train clinicians in communication and other things, but also how can we put together trainings and skills work for patients and caregivers in managing to enhance their skills? And then, of course, access to social work, psychology, psychiatry. We think about social safety, so support groups, caregiver family support in the community, and then any structural needs that come up, housing, insurance, care at home. There's so many things that people are thinking about here. And then again, just the hope prepare model. So what's most important to people and to their families? And then how can we think about planning and preparing for the future? Everything from financial, legal, advanced care planning, identifying decision makers. And this doesn't happen all at once, but the idea is just to have there be a personalized and comprehensive plan that allows people to feel like they have, they have this care, this comprehensive plan after receiving a diagnosis. So I will pause there. And now I'm going to ask Carolyn to share her experiences. I think you're on mute, Carolyn.
Thank you. I couldn't take enough notes because I've lived all of that, all of that. I will just say that I'm going to start off talking. I'm going to do some time traveling, talk about my mom. I was a caregiver as well, as several of you have noted. She was a really spunky, independent, bright, courageous woman. And her decline was, very difficult to watch, very difficult to watch. And in the 80s, when she was diagnosed, you know, there were there was nothing, very few things. She went to a neurologist. He gave her so much medication that she couldn't stand up. Yeah, yeah. I mean, I could talk about this for a week, but I won't. But her eventual decline and my caregiving really gave me the information that I needed myself to make a decision about participation, and active participation by education in a clinical trial. There's so much to learn by observation, so much. So, we moved through that with great difficulty, but I learned how to cope, and I learned what she needed, and I learned how to watch her behavior. So then we're going to fast forward to 2015. My husband, who was a wonderful husband and a wonderful musician, passed away, and it was a very difficult time in my life, as you can well imagine, extremely difficult time in my life. And right after he passed away, I was contacted by card and just a blind mailing. Would you like to participate in a clinical trial? And I thought, how did they find me? Who knows? And nobody can ever tell me to this day how I was targeted or if I was targeted. Anyway, I thought about it for a long time, and I talked to Nancy Koppelman for three or 4 months. I said, I'm just not ready to participate because I have to really do some really deep thinking about if I want to know, if I really want to know. And then I decided that, as you said, Dr. Paladino or Joe, when you know, you can live your life differently. Some people choose to make decisions they would not have made, and I have done that since 2015, and it's given me hope and another life and a more experiential way to live because I know this might happen to me. I started in the A4 in 2015 because I wanted to prepare for the future, as I've said. I right away there was excellent rapport with the clinicians that I came in touch with our support group, many of whom are here today, the conferences that we attended. I mean, not was it just like these are people like me. I mean, we really cared, and I looked at those people and I thought, gee, do they have dementia? Gee, is this something happening to them too? Do I look, and I all of a sudden I realized that I had stigma about what it might be or what might happen to folks. So, there's safety in numbers, but in my case, it was more than safety, it was encouragement and support. Let me see. Again, I use the phrase knowledge is power. Knowledge is power. I'm just talking to your clinicians, talking to your neurologist. I have a neurologist now. He's wonderful. He's at Brigham. Very kind, very open to me, very warm, very even complimentary, if I could say. And when he gave me information last June or August, well, you did really well in your cognitive testing and you present and you're basically okay. There's nothing we can do. I can't follow you because you don't have enough symptoms. And I was disappointed. Interestingly enough, I was disappointed because I couldn't be followed as closely as I wanted to by this wonderful clinician. So, that I don't know if that's something that other people experience, but he said, well, it's good news, Carolyn. So accept the good news and soldier on. And I have. So I have now morphed into the AHEAD study, 2.5 years into the AHEAD study. It hasn't been easy for me. It's a very time-intensive study. Every 2 weeks, there's some sort of clinical intervention. We have lots and lots of MRIs. I have had 2 microbleeds. I just had another microbleed recently, which the first one just terrified me. It really terrified me. I didn't know what that meant. And at the time, I was in a doing a lot of my head was involved in other things, and I really found it difficult to deal with what I did not know. So I made a lot of noise to my caregivers about, you just can't leave somebody on the edge of the cliff. You have to let them know. You have to tell them what to expect. You have to reach out to them. You have to use some TLC to your patient who's in a clinical trial. And I think that my yelling and screaming mildly made a difference, which I'm happy about. Because after this microbleed, I got a call and, well, what are your questions? Right away, I saw, a year later, I saw a distinct difference in the response, and that made me feel even better. So, am I worried? No. The three questions I asked, I'll be really brief. Is this because I have plaques and tangles, which, by the way, I have a growing plaque load? Well, maybe. Is this because I might be taking the medication, which can also do some damage to your brain? Well, maybe. Could this be normal aging? Well, maybe. So after I asked the questions, I'm not sure, which actually was quite reassuring because one of the things that I know is that with a plaque load that's growing, which I have, I may never develop. I may never, but I chose to continue to be in the milieu. I'm always going to be in the milieu because I do want to access everything that's available. And the fact that we are here in Boston with a huge, huge amount of expertise and research studies and clinical trials. I mean, we couldn't be in a better place. So to finish up, it has been a great pleasure and a joy, scary at times, emotional at times, sad at times, for me to participate in this, but it's life enhancing. The bottom line for me is it's a good thing. And thank you for asking me to speak today.